All right, we're about to dive into a fascinating diagnostic mystery from the New England Journal of Medicine. This is one of those cases that starts with a symptom you see every day, a headache, but ends with a diagnosis so rare it's basically a masterclass in clinical reasoning. So let's get into it.
So, an 18-year-old comes in with a headache. You see this all the time, right? But the question is always there in the back of your mind. Is this just a bad migraine, or are we looking at something way more sinister? Well, this case is going to push that differential to the absolute limit. So, first let's meet our patient and start trying to piece together this puzzle, which, believe it or not, have been building for over 6 years.
Okay, so the official story begins right here, in the ED. The chief complaint? A worsening headache and hypertension. But as you're about to see, this was really just the final act of a much, much longer drama.
And when they say hypertension, they're not kidding. We're talking a full-blown hypertensive emergency. Her pressure when she came in was a staggering 207/143. Now, in an 18-year-old, a number like that just changes everything. So let's look at this timeline, because it really shows you how slowly and insidiously this whole thing progressed. It all started 6 years ago with just some on and off headaches. But then, about a year ago, they became daily, and they were waking her from sleep. That's a huge red flag, right? Then, 3 weeks ago, morning nausea kicks in, all leading up to this debilitating, crushing headache that finally brought her to the hospital. The initial workup immediately confirmed this was a systemic crisis. The fundoscopic exam showed papilledema, a clear sign of severe intracranial hypertension. Her opening pressure on the lumbar puncture was 36, nearly double the upper limit of normal. And her chest X-ray even showed pulmonary edema. It was clear the headache wasn't the problem, it was a symptom of a body in total crisis.
Okay, so with severe secondary hypertension confirmed, the hunt was on. They had to find the root cause.
And one of the very first, most critical clues came from her basic labs. A potassium of just 2.0. I mean, wow. This profound hypokalemia, especially with that crazy high blood pressure, really narrows down the possibilities. It points the investigation squarely at either an endocrine or a renal cause.
Now, in a young patient, you've got to cast a wide net for secondary hypertension. The team had to think about everything, from renal disease to vascular issues like fibromuscular dysplasia, and of course, a whole range of endocrine disorders like Cushing's or hyperaldosteronism.
Given the episodic nature of her symptoms over the years, those headaches and high blood pressure, a pheochromocytoma was way up high on the list. I mean, it's the textbook cause for this kind of presentation, so ruling it in or out was an absolute top priority. But the workup was negative. Her plasma metanephrines were totally normal, which makes a pheo highly unlikely. So just like that, the number one suspect was off the table, and the mystery got even deeper.
So after ruling out some of the usual suspects, the investigation hit a major turning point. Two critical findings were about to blow this case wide open.
The first big break came from imaging. A CT scan of her abdomen showed this small, hypodense lesion on her left kidney. Now, a lot of these turn out to be harmless incidentalomas, but given our clinical picture, this was a huge discovery. And then came the second clue from her labs. And this one is just shocking. Her plasma renin activity was 150. To put that in perspective, the normal range is between 1.2 and 2.4. So her level wasn't just high, it was astronomically off the charts high. So how do you connect the dots between a tiny mass on the kidney and a renin level that's through the roof? Well, the team put these two massive clues together and came up with a single, very rare diagnosis that explained everything. The final diagnosis was a reninoma. It's a rare, usually benign tumor made of the kidney's juxtaglomerular cells. This tiny little tumor was basically acting like a rogue factory, just pumping out insane amounts of renin, which in turn was driving her severe hypertension and causing all that potassium wasting.
And here it is, the definitive proof from pathology. On the left, you can see the whole tumor, nice and encapsulated. And then on the right, under high magnification, you see the dense cluster of those little renin-producing cells that were the source of her 6 years of misery.
And the cure? A robot-assisted partial nephrectomy. It's a minimally invasive procedure where they go in and just resect the tumor itself, preserving as much healthy kidney tissue as possible, which is obviously so important for a young patient. In fact, she was out of the hospital the very next day.
The result was absolutely immediate and dramatic. I mean, think about it. After a 6-year battle, where she needed a half dozen different meds just to get her blood pressure under some control, she was now completely normotensive, no medication at all. It was a total cure.
But wait, the story isn't quite over yet. While the surgery cured her hypertension just like that, one very dangerous symptom was still hanging around, and it presented one final clinical puzzle.
So check out these numbers. 3 weeks after the tumor was gone and her blood pressure was totally normal, her intracranial pressure was still severely elevated at 32. So the question is, why? The source of the problem was gone, so why was her brain still under so much pressure?
Well, the proposed mechanism is pretty fascinating. The theory is that those years of profound hyperreninemia led to a state of hyperaldosteronism, and that in turn is thought to stimulate receptors in the choroid plexus, which actually ramps up the production of cerebrospinal fluid. So even with the tumor gone, it was just going to take time for that overproduction to quiet down.
And that's exactly what happened. They treated her with acetazolamide to manage that pressure. Over the next 6 months, her headaches, the papilledema, her visual field defects, they all completely resolved. And after this incredible 6-year ordeal, she graduated from high school and went off to college. I mean, what a truly remarkable outcome.
So we end on this question. This was a zebra, right? An exceptionally rare diagnosis. But it started with one of the most common complaints we see. So how does a case like this change how we approach a common symptom? I think it's a powerful reminder for all of us to stay curious and to always consider that what if in our day-to-day practice.